Good evening. I'm Digitalizing, Vice President Research and International at the University of Manitoba. The Café Scientifique program is sponsored by my office and is managed by the staff in my office, particularly Janine Hermschek and Fred Munson. The purpose of these Café Scientifique, when they got initiated, was to bring the university's excellent researchers to a public setting, have a very easygoing conversation. That means there is a work for you to do also, to participate in that conversation. It's not lecture style. They would give you a brief overview, and the moderator this evening would give you the more ground rules. The topic today, which has attracted you, is the choosing wisely, why more medical tests are not always better. And tonight's expert will be sharing their perspective on that particular topic. And I would like to introduce your moderator for this evening, who will tell you more about the panelists and also will tell you some of the ground rules that will guide the discussion this evening. Dr. Eric Wong is a professor of surgery in the Rady Faculty of Health Sciences. He works at the Concordia Hip and Knee Institute, where he specializes in primary and revision hip and knee replacement surgery. His areas of research interest include access, appropriateness, effectiveness, and safety of healthcare, clinical registries, clinical trials, implant retrieval analysis, and radiographic stereometric analysis. He currently chairs Manitoba's Provincial Orthopedic Standards Committee and the Advisory Committee of the Canadian Joint Replacement Registry. He serves as medical advisor to the Winnipeg Regional Health Authorities, Orthopedic Waitlist, Joint Replacement Registry, and Central Intake Program. He is also a member of the George and Fahey Center for Healthcare Innovation, where he serves as director of their health system performance platform. He is a co-lead for Manitoba's Choosing Wisely initiative. Please welcome Dr. Eric Boom as your moderator for this evening.
Thank you for the introduction and kind words. And again, thank you for the university's support of this event. Thanks for coming out. I'd also like to thank Sarah and Michelle for their hard work and support for the university in this process. So as Dig here mentioned, I do have some ground rules that have been laid out for me. I'm going to share with you, so we're all on the same page, right? So each of the three panelists you see here will speak for 5 minutes about their perspective on Choosing Wisely campaign. And after they've all spoken, I'll open up the floor to discussions. I'll walk around with the mic so you can ask questions of our panelists. And certainly your participation is an important part of this evening. We are recording this presentation for later uploading on the Café Scientifique website, and a link to the video will be available on the Manitoba website later on this week. So after the speakers have spoken, I'll take questions up to about age 25, at which time we'll wrap things up. No? Yes.
It's in the ground rules.
So I got to see it. I have to read them out. There's food over here if you haven't found the food already, so please help yourself and eat the food because we can't take it all home. And there's also evaluation forms on your chair, so please fill those out. They're very useful for us in planning this kind of event and improving things. And just a reminder for everybody, before we get started, that this is a discussion forum, and we ask that you do not ask for specific advice on medical conditions and so forth. It's a general discussion of the Choosing Wisely campaign. So as we've mentioned already, we're gathered here today to talk about the Choosing Wisely Canada campaign. And it's a health education campaign started in 2014. And it aims to help physicians and patients engage in conversations about unnecessary tests, treatments, and procedures. And this is to help people make informed and effective choices to ensure high quality care. The campaign is based upon the notion that unnecessary tests, treatments, and procedures often do more harm than good. They result in poorer clinical outcomes and can result in significant waste in the Canadian healthcare system. Unnecessary tests, treatments, and procedures can take away from care by potentially exposing patients to harm, to leading to more testing to investigate false positive tests, and by contributing to unnecessary anxiety and costs for patients. So central to the campaign are lists of 5 things physicians and patients should question. And these top 5 lists have been developed by the national medical societies across Canada, and they're available on the Choosing Wisely website. There's quite a few recommendations there. Now, equally important to the list, of course, is the role of patient education and the need to dispel the myth that more care is better care. And certainly a recent CIHI report looking at 8 recommendations found that up to 30% of tests were not necessary. So this really is an important issue across Canada. So on that note, I'm going to introduce our 3 speakers from my left to right here. Bios as well here. So to my left is Dr. Roger Süss. He is an assistant professor in the Department of Family Medicine at the University of Manitoba. He's a primary care physician who's practiced both rural and urban settings in Manitoba since he graduated from the U of M in 1988. He has experience working both in family medicine and emergency medicine, and currently is teaching medical students and family medicine residents to use medical tests and imaging judiciously and thoughtfully regardless of the setting of their practice. Next to speak will be Dr. Alex Singer, who's an associate professor in the Department of Family Medicine at the University of Manitoba, where he leads the Quality Improvement in Informatics curriculum. He is the network director of the Manitoba Primary Care Research Network and is the Manitoba eHealth Family Physician Champion. He's also a clinician teacher at the U of M's Family Medical Center at St. Boniface Hospital. He's currently working with Choosing Wisely Canada and Manitoba campaigns on initiatives involving antibiotic stewardship and reducing unnecessary laboratory testing. His active grant-funded research studies include a new focus on using electronic medical records data for secondary use, specifically in the areas of natural language processing and pragmatic clinical trials based in primary care settings. And Dr. Michelle Krieger is a professor and graduate program director in the Department of Community Health Sciences, a former Tier 2 Canada Research Chair in Environment and Health Risk Communication at the University of Manitoba. Her program of research examines harms and benefit communication in primary care and public health. She's particularly interested in how public audiences can be engaged meaningfully to enable informed decisions, both informed choice as well as informed refusal around health recommendations. Her research explores these aspects with both general population residents and with Manitoba Métis. So please join me in welcoming our 3 speakers. Roger to give us sort of a bedside perspective around choosing wisely. And then I'll ask Alex to speak, and he'll add some local data and findings on unnecessary care. And then Michelle will speak to us about the important components of an effective patient-clinician relationship. So, Roger.
Absolutely. Stand up and take your mic over here. So, what I'm going to talk to you about is try to help you understand how doctors think and what doctors are thinking about when they pick what tests to order. I'm going to assume a couple of things. I'm assuming that you are a very intelligent audience, but that you have no particular medical background. So that's kind of where I'm trying to the level I'm trying to communicate at here. I have 5 things I want you to take away from this. The first is that in trying to understand this whole issue, it's very important to think about things in terms of shades of gray. That if you think about things in terms of black and white, or even black, gray, and white, none of this is going to make very much sense. The second thing is that the probability of disease occurs along that spectrum from black to white. And when we say that you have a disease, as opposed to being black, being kind of like close to black, you almost certainly have the disease. And at the other end, white, people think when we use the terms that you don't have this, you probably don't have this. So you have to stay on that sort of spectrum. White means almost white, black means almost black. Now, tests also occur kind of along a continuum. A perfect test, a perfectly accurate test, would classify everyone who took it either as having the disease or not having the disease. 100% of the time it would be right. That would be a perfect test. There are no perfect tests. And the closer that it gets, the better, the more accurate the test is. But it's important to understand that not only can tests be falsely negative, tests can also be falsely positive. So what does that mean? It means the test says that you have the disease and you don't. That is one of the big risks of tests. You may think that kind of, well, it's not my money anyway, the government's sort of paying for it, maybe I get a little bit of radiation. One of the big risks is that if you get tested and you don't need it, is that you will have a false positive test. And that may mean that you get treatment that you don't need, and you're exposed to the risks of all of those treatments. So when you put all those things together, you've got problems. Because if your probability of having a disease occurs along a continuum, and if you are at the almost zero end, and you get the test, you are more likely to have a false positive test than you are likely to have a true test, or a truly positive test. So that test can do you significant harm if you're at the very low end, if you're at the almost zero end of that scale. So doctors need to identify who to do the test on. So we need to do the test on people who are really kind of in the middle of that gray zone. And the way that we do that is are called red flags. So red flags could be symptoms, could be family history, or there are other factors that tell us as physicians that you are in the gray zone. And if you're in the gray zone, then the test is a good idea. If you are in the nearly white end, the test is probably not a good idea. So to just run this through, sort of, if you think of like one patient, imagine a patient came to see me this last week. A young man, headaches, and he's concerned that he has a brain tumor. So one of his problems is that he is thinking about this, not in terms of the continuum, he's kind of thinking about this in terms of white, gray, or black. And he's kind of going, well, I know that there are some people, young people who have brain tumors sometimes. I know my probability isn't actually zero. And therefore he goes from there to kind of say, so I guess it's gray. And he jumped over to like the 50% range. And he wants to see about getting the test because he wants his risk to be absolutely zero. So he comes to see me. I'm going to use those red flags to try to identify whether he has any sort of risk factors. And most young people won't have any of those. And I will tell them that I don't think that he needs that test. If we go ahead and do that test anyway, we could have serious problems because he probably doesn't have a brain tumor, but he could have a false positive. We could find something on that CT scan of his head that has been there his whole life. Never bothered him. It's just this like thing that was like sitting there. But on the CAT scan, I can't tell the difference whether it's a brain tumor or not. Now he has to have further testing. And even if that testing is as simple as getting repeating testing later, and he's like, no, I don't think that is a brain tumor. Imagine he was anxious before. Imagine how anxious he is now. So my message to patients is that it's very important to think of things like a long sort of long continuum of scales of gray, and to accept almost white, that's white. If your risk is like really low, it's not, I know it's not zero, but it's really low, the test is likely to cause more harm than good. With family doctors, my message would be that you need to learn the red flags to identify who's supposed to get the test, who needs the test, what are the risk factors for that. My message to researchers would be that it would be very helpful if we could get tests that were more accurate. That would help. But we could also use help identifying what the red flags really are. And we have research ongoing around issues like that. And my message to the family doctors would be to learn the red flags and not to expose your patients to risk if they don't have any of those red flags.
Great, thank you very much, Roger. So what I think we'll do is we'll have all three speakers talk, and then we'll open up the floor to discussion. So, Alex, do you want to use your mic? Do you want to use my mic? Do you want to walk
I might
around?
stay seated.
Okay.
I'm much more likely than Roger to wander.
Get lost.
And I have a piece of paper because I have some numbers. I won't give you too many numbers, but I wanted to sort of focus in from where Roger left us, which is very much at the bedside or at the doctor's office. And I'm gonna both drill in a little bit, but also look at this sort of from I'd say like a 30,000 feet view, looking at health systems and looking at multiple practices together. So much of my research revolves around using electronic medical records, which are basically what most doctors now in the province, about 85% or so, use to document their care. So when you go to see a doctor, you probably have a computer in front of them. Spend some time typing and putting some things in there. And so my research revolves around actually extracting that data, processing it, and using it to try to describe the patterns of care. And one of the patterns that I've looked at, and that we looked at specifically around Choosing Wisely, is when certain tests or treatments are being used in a way that suggests that they're probably unnecessary. And I don't like the term unnecessary, but I'll use it occasionally, and I think when I say unnecessary, what I'm really meaning is potentially unnecessary. Because we actually don't have you're talking about tests, we don't have this specificity, we don't have a specific enough measure when we look at all these records together to know, is an individual test definitely unnecessary or definitely necessary, but we can look at some of the patterns, and that's what some of the work I've done has done. So Eric mentioned about Choosing Wisely Canada, which has a series of lists, and a number of those tests on those lists are relevant to primary care. And so what we did was we looked at 4 specific tests and treatments, 2 tests and 2 treatments. The treatments related to using antibiotics for infections that were likely to be viral. So antibiotics are really good drugs if you have a bacterial infection. If you use antibiotics for conditions that are viral, well, they don't work and they expose people to harm. The other treatment we looked at was the use of a particular type of drug used for psychotic diseases, but used in the presence of older people who have dementia. And when you use antipsychotic drugs for patients with dementia, you have to be really careful about who you choose and how often you use those medications, because they actually cause significant amounts of harm. The challenge is they're sometimes very useful. So there's kind of you might say like a sweet spot, where if you're using these drugs judiciously, you can actually sort of maintain some health of patients, and they can be a benefit. But if you use them sort of non-judiciously, they can actually cause quite a bit of harm. The 2 tests we looked at relate to testing for vitamin D, which is essentially useless. Vitamin D testing provides no value. Everyone in this room is more or less vitamin D deficient because you live in Winnipeg. Some people that maybe got a little bit more sun this summer or spend the winter in Phoenix, but even still, if you wear clothes, you're probably, and you're white, or if you're dark, you probably still are low in vitamin D, and testing your vitamin D provides no benefit. You should just take vitamin D sort of regardless, and testing it doesn't tell us anything, because it could be low, it could be high, you still need more vitamin D. And then the last test we looked at was it's called the prostate-specific antigen test, so PSA for short. Some people have seen or heard about the PSA. So the PSA test is sort of controversial, but essentially in the last, say about 5 to 10 years, it's become more and more apparent that the use of this test for screening is really not helpful. It actually causes more harm than good from a screening point of view. So screening means using the test for healthy people, not people who we suspect have disease. So somewhere on that spectrum where Roger talked about, screening tests get done for everybody. Whereas if you're using it for people who have symptoms, it's a slightly different story. So we looked at those 4 treatments. And we did this assuming that we would find a fairly high frequency, because there's, as Eric mentioned, some studies from Canada that show about 30% of the care that's delivered in some measures is potentially unnecessary. And there's some American studies that say about the same thing. It's about 20 to 30% of the care that's delivered is probably not improving patients' lives and extraneous and probably just causing more harm than good. And that's hard, because to find that 20 to 30% is actually trickier than you might imagine. So what we did was we actually looked at the electronic medical records. We looked at those four treatments and tests, or the two tests and the 2 treatments. And we used a database that I help administer and I direct, that extracts data from the electronic medical records from about 240 primary care providers, so mostly family doctors, some nurse practitioners. And in our population that we looked at, There's 164,000 patients represented that received care over a 2-year period, okay, between 2014 and 2016. So that's 164,000 patients with multiple visits that each patient might have had. And we use statistical models to try to describe the patient and the provider characteristics that may or may not lead to sort of patterns that look like their testing is unnecessary potentially. And so we identified about 16%, so it's about 25,000 patients who had been exposed to a potentially unnecessary test. So that's a little bit lower than some of the other studies, but we were looking at 4 very specific tests. Had we included a broader range, we might have had actually slightly higher numbers, but that's what our study captured, about 25,000 patients who'd been affected by one, but sometimes multiple of these potentially unnecessary tests. And what we did was we tried to use statistics to try to describe what's the about right, what's the sweet spot. And so when you do this, you can rank all the tests, and you can actually see that a small number of providers, as the primary care providers, actually account for the largest number of the usage of these tests. So for each one, it's a little different, and in fact, it's not the same providers who are using some of these tests in a way that appears that they're unnecessary. So because you can look at, so if you take prostate-specific antigen as an example, so a PSA test, Sarah over there and Roger and I just had a meeting about this earlier, you can actually identify from the data what's about the right, quote-unquote, or the sort of low-range use. And that ends up being about 5% of a person's practice if they have an average-sized practice, or somewhere in the range of about 50 tests a year. So that seems to be about the judicious use. But then you have some providers who are using this test hundreds of times a year. So it suggests that they're using it for screening. And that's actually a small percentage of the total providers in the province. And so you can use that to sort of try to improve the quality of care by identifying who those providers are and who the patients are potentially that are more likely. And so we looked at some of those factors. And things like the provider characteristics, so the provider's age, the size of their practice, where the practice is located, provider's gender in some cases for some tests, actually relates to how likely they are to actually overprescribe or overtest. And similar things you notice in patients, or we notice in patients when we looked at this. So things like patient's gender or age and how sick they are, how many other diseases they have actually affects how likely they are to get an unnecessary test. Some of this we expected to find. So if you think of patients who are a little bit sicker, who have more conditions, more diseases, some of these things are probably more likely because they're presenting with illness, with other illnesses. And so you would expect some of those things to occur. But when when these tests are used non-judiciously, that's when we think we have a problem. The study's not perfect. It doesn't tell us, as Roger was going into that kind of detail about the nuance of what's in the patient encounter, and I think Michelle's going to talk a little bit more about this nuance too. This study doesn't tell us the clinical factors, what led to the test being ordered or done, and what the patients came in thinking or what the doctors were thinking when they ordered them or used the treatments. They just tell us about the general patterns. We just finished up another study that's actually looking at trying to provide audit and feedback. So reports that go to the physicians and the nurse practitioners to try to motivate them to change their behaviors. And we've noticed a small improvement, very similar to some other studies that used a similar technique. So providing reports to the provider that show them what their practice looks like and hoping that that will motivate them to change. And there's some more studies going on, and in fact some that I'm participating in and Michelle's leading and other people are working on, that are looking to try to better understand this provider-patient interaction and what's motivating some of this care. Because one of the things we want to try to do is curtail the use of these potentially unnecessary tests. Because if we can get that rate down, if we can get those numbers down, not only will we improve patient care, so we'll reduce harm because of side effects and things like that, or further unnecessary tests, exposure to things that wouldn't help someone's health, but also we can reduce and curtail some of the costs, and that's really a secondary outcome, but it's important because we don't have an infinite system. And so that's all going on. I'm going to finish with one shameless plug. One of the studies we're doing to look at this in greater detail, I'm actually asking for people to help advise us, or citizens, patients, people out there. So at the end, if you feel really motivated to continue talking about this topic, or continue asking questions and answering some questions, there's a sign-up sheet in the corner, and you can have a cookie and sign up to participate.
Thanks, Eric. So you've heard a little bit about how things ought to go when you go see your doctor, and the things that they think about or try to think through when you're there. And Alex has been kind of outlining a little bit about what he's seen within the data when he spent a lot of time looking at this. And the kind of research I do involves talking to people. I love talking to people. And we all know, everything I say is going to be all present company excluded, right? We are not any of the people that I'll be talking about, and these providers are not like any of the providers that I might be talking about. But we all know people in our lives that we might say, oh, they're overusers. Like, they go see the doctor for absolutely every single thing. If there's a hangnail, they're off to see the doctor. We also know, and probably have some in our family, those people we would call underusers. It has to practically be falling off before they maybe will actually go see a physician to see if there's maybe something wrong. So we've got these really broad spectrums. And then we have all of these different kinds of patients, the kinds of people that go to see their physicians. You've got people who are, they're very accepting. They go see their doctor says, you know what, I think it's this, I think we should do that. You're like, okay, that's fine. There's not going to be a question of the doctor of, is that test really needed? What kind of information are we going to get from that test? Like, what's it going to tell us, and how might that change what I do? Because it's just, I'm just going to accept, doctor knows best, I will follow. Then you have some of those pushy patients, the people who follow Dr. Google, Dr. Oz, anything that they hear about, and all of a sudden they start to think, maybe I have that. So they go see their doctor. So they're that young man, they go in, I've got this headache, these headaches, and maybe it's a brain tumor. I really need to have the tests that are going to tell me if it's a brain tumor or not, because I'm really worried. Well, so you have somebody like Roger saying, well, no, it's not really a brain tumor, I don't really think you need it, and goes through a full spiel. And maybe that person is still unhappy. So then they're going to go see Alex. And they're not getting satisfaction with Alex, so they go see Eric, and they keep going through until they finally find a provider who's going to actually do the test that they feel is really important. Now, all of us are intelligent people, but these gentlemen who have specialized in medicine, they know more about a whole lot of things, and we count on them to know more about a whole lot of things. So when we sit down and we talk to them, and we run through how we're feeling or what's going on, they're already mentally checking out, okay, it couldn't be this, it might not be that, okay, well, I've known, they've seen me about this, that, and the other thing before. And so they arrive at a point on that landscape of what it could be and what might be useful way faster than we ever get there. So if we want to actually try to catch up with the logic, because of course they have to be patient while we ask some of our questions to make sure that we're kind of on the same page of where they are, sometimes that kind of active role that we play to ask the questions to find out, well, is that test, what's it really going to tell us? Is it really going to change anything I might do in my life? If knowing that, is it really going to be all that useful? Sometimes it might be misinterpreted in those doctor-patient visits because, the doc and, everybody's been in the waiting room, right, for however long it's been, because the provider's been spending their time talking to the patients that have been seeing them. So, when you finally get your turn, you go through your things. So you start asking your questions, and the doc is like, oh gosh, you know what, this person, they're pushy. I'm going to just order the test to placate them and get them moving on their way. So sometimes they can make assumptions about how we're presenting, how we're asking questions, and think that maybe we're actually one kind of patient when maybe we're another. Or they have people coming in and they're worriers. And the physician can see that, oh my gosh, I don't think it's this, but this person is so worried. The anxiety that they are contributing in their own body, worrying about this, it might actually do them more benefit to have access to this test because of their concerns than it is to try to go into the big spiel about why maybe they don't. So we've got these full spectrums. But now what happens when you have the distrusting patient? The distrusting patient is the person who maybe has had a lot of bad interactions in the health system. Maybe they've had experiences when they've got in because when they go see a physician, they don't have a regular doctor. They might feel that, well, the doctor makes judgments about me before I've even opened my mouth. Maybe it's because I look poor. Maybe it's because I look Indian. Maybe it's because whatever. They have distrust. And maybe it's even at a subconscious level. They don't even know why they're distrusting of what's happening, but there could have been some, long-standing trauma that they've underwent from within families, residential schools, with children being removed, with other kind of environmental harms, with newcomers that come to the country where they've gone through refugee camps and other things. There was a whole litany of things that are going on in this really short interaction with a physician and trying to figure out what's going to be the most necessary for you or not. So in that situation of a distrusting patient where they go in, and now the doc says, no, we really don't think you need to do this. Well, if that person hasn't seen a physician regularly, they might be presenting with some symptoms, and so as Roger goes through his things, he might be thinking, well, there's really no red flags. But Roger doesn't really know me all that well, so maybe if I had also explained these other things that I've seen different providers for, then maybe that might have formed a red flag. So it gets missed. And the thing that you want to make sure that comes out of initiatives like Choosing Wisely is making sure that we do this thoughtfully, that we do this sensitively, that it's, nobody in the system is an automaton. Everybody is trying to do the best they can, but we want to make sure, and the reason we do the kind of research we do is to make sure that there is still trust at the end of the day. That when you go see your provider, and if your provider says, you know what, you don't need to have this yet, I think what we really should do is maybe wait, but we'll monitor it. And as long as you walk out of that feeling, okay, the doc has my back, the doc is looking after my health as much as I want my health to be looked after, that's a good outcome. It's when you walk out thinking, they're not ordering it because my life doesn't matter. They're not ordering it because they don't think I matter. And then you start to lose that trust. It's those areas which are the kind of research that many of us have gotten into around this to ensure that it is seen in the best way. We're using the test judiciously, that we're not using treatments unnecessarily and causing people and exposing them to unnecessary harms, but doing it in a way that's thoughtful. So that's it for me.
Thank you very much to our three speakers. So I'm going to take the moderator's prerogative and ask the first questions of our speakers, then I'll open up the floor to discussion. Roger, you've used the term red flags. Perhaps you can help me understand a bit better exactly what a red flag is. If I come to you with some low back pain, for example, I might be asking for an x-ray of my back. What kind of red flags would you be looking for to persuade me from not having a back x-ray, for example, as you would give?
Well, like a foot. I'll switch examples. I'll go back to my headaches. For reasons that I won't explain. So there is a list of red flags for headaches, which can identify who is at risk, who is out of the sort of like on the near zero end of the spectrum, and therefore needs further testing to find out whether they're at risk or not. So as it relates to headaches, like that list is, there's a mnemonic for remembering it. It's SNOOP, which is, S is about systemic factors, so fever, weight loss, systemic disease, so HIV, cancer. N is for someone who has like neurologic symptoms. So those at the dramatic end would be things like seizures, one part of your body doesn't work right, kind of losing sight in sort of one eye all of a sudden. Sometimes so there's a whole list of those. Let's see which other ones to talk about. Age, sort of new onset of headaches beyond age 50. A change in the pattern of you've had headaches forever, but all of a sudden they're sort of very different. So some of them are symptoms, some of them are things that are like physical findings on examination. Some of them are family history. Those are the kinds of things.
So if I come to you and don't have any of those red flags, it's fairly safe to assume I don't have something bad going on in my head and need a CT scan.
Right. As long as you understand that we're talking about those shades of gray, so we're talking about the near zeros or N, which also means that we will not get 100% So that one of the things you have to realize inherent in that strategy is that there are going to be times when there are 20-year-old men who go to see their doctor, have no red flags, and a couple of them in the population are going to have brain tumors. But if we went and took a strategy of trying to get 100%, at some point you start to get more false positives. You start to cause more harm trying to get those last few. So that there is a benefit to pursuing the middle part of the spectrum, and as you really try to push it to try to get to 0%, you cause more and more harm in those last few percent.
Thank you. So as a question I wanted to ask you, Alex, is this concept of a false positive test leading to unnecessary interventions or harms. You give an example of PSA. You want to use that example, talk about what a false positive test is and how it might lead to bad side effects from further testing, or another example if you like.
Yeah, so with the PSA test, I think one of the issues is that because the blood test, the immediate response is, well, the test isn't that harmful, right? Like, it's just a poke. Like, I don't mind. That's not that harmful. Like, I get a little bruise, it hurts for a few seconds, I lose a milliliter of true blood. Like, that's not so bad. Those aren't real harms. And the real harm of the PSA test actually comes in what we call the downstream effects. That's actually one of the things I'm going to be studying in that thing that you should sign up to help me with, is the downstream impacts. And so for the PSA test, the kind of downstream impacts that we see is because the test has a lot of false positives, what you end up doing is a lot of unnecessary secondary investigations. And so it's the tests that come from that initial false positive, sometimes called a cascade of tests, that those tests are the ones that cause harm. So in the case of PSA testing, the most common secondary test is to go do a biopsy. So biopsy means putting a needle or some kind of surgery to take a piece of the prostate out. And the prostate is in a pretty sensitive area. Only men have prostates. It's in a fairly sensitive area. And so the consequences of those biopsies are things like incontinence, so not being able to hold in your pee, impotence, so not being able to get an erection, which men often don't like very much, and infection, so getting a bad infection, and bleeding. So those things are all pretty bad. And those happen at pretty low rates. But then the biopsy itself also has risks, because the biopsies often have false positives. So a certain percentage, and I don't remember all the numbers off the top of my head, but then a certain percentage of those biopsies will be a false positive. So if you biopsy 1,000 men, you're going to get several hundred false positive biopsies, and that leads to an even riskier treatment, which is a surgery to take out the prostate. So then what happens is you take out the prostate, and now you've been exposed to all those same risks: incontinence, impotence, bleeding, infection, but at much higher rates. And often, the cancer that you removed wasn't actually going to harm that person, in terms of the fact that with prostate cancer, we know you're actually much more likely to die with prostate cancer than from prostate cancer. And the really unfortunate thing about prostate cancer that makes it even trickier, sort of sits outside of this, is that the prostate cancers that often kill people, because prostate cancer does unfortunately often kill people, are actually not the ones that get picked up well by the PSA test. So the tragedy and the challenge of PSA testing is, while people die of prostate cancer, and it's an awful disease, and it'd be great if we had a wonderful treatment and a great test and great cures, we don't. We don't have a great test to pick it up. So, in fact, unfortunately, people die of prostate cancer even having had the test, because by the time they go and get tested and have a biopsy or have a prostatectomy that's removing the prostate, they might already have their prostate cancer has spread. And so the test doesn't actually save people's lives, which is the real trick with it, and why it becomes a really difficult situation, because many people know someone who's had prostate cancer, survived or died from it, or had it affect them. And unfortunately, we don't have a great test to help us intervene early to stop what we want, which is people dying from prostate cancer.
Communication between, obviously, providers and patients and making a decision around having a PSA test. So, Michelle, one of the things that at least the three of us always do in the office is try to develop good communication and rapport with our patients. You mentioned the importance of trust. Can you offer any sort of pearls from both the clinician's perspective and perhaps the patient's perspective on how to improve that communication, that trust between providers and patients? Anything I can do, anything people here can do, one thing or two things that we can do to help improve the communication and decision making?
I think improving communication is around the listening, but the biggest challenge in the clinical encounter is that it's not just the provider and the patient who's in the room, right? Depending on the issues of PSA is a great example. You've got advocacy groups like Prostate Cancer Canada who is advocating then go out and get your PSA test. Get your number, know your number. It's just a piece of information to add into your arsenal of how to maybe manage your health. Women get the same message of mammograms, and we've all heard the message. I did focus groups talking to men and women about PSA tests for men, mammograms for women, and everybody said the same thing. You know, if you catch it early, they can do something. You know, early detection is your best protection was something that was said to me so often. It was a really effective communication campaign about the importance of screening tests for otherwise healthy people to make sure that we can try to curtail some of these numbers. So there's all of that noise that comes into that clinical encounter, which sometimes makes it really hard for the doctor and the patient to actually have an honest conversation around what really is important for you as a patient and for you as a physician in trying to work through some of that. I think the biggest challenge would be if somebody walks out feeling that they weren't heard and their concerns weren't addressed. And sometimes that there are different kinds of physician offices where it's maybe we only want to hear one major and maybe one minor complaint that you have. Well, quite honestly, I am not a walking symptom. I am a person that has a whole bunch of complex things that go on at a particular point in time. So if you want patients to be able to communicate effectively, part of it is also telling them how to communicate effectively. So we had a study where there were people that would come in with their diaries. They had rheumatoid arthritis, and they would go through their long diaries for their physicians about this is everything that's been going on. And all the physician wanted to know in the last 7 days, you know, how has it been for sleeping, or how has it been for this? Because then they can tally that information and then process it in a way that might help the patient best. So trying to work through where a patient wants to go through an entire story and maybe the physician just needs a few nuggets. So it's trying to even talk about how do we try to share the information about the symptoms for a way that is useful, but then how do you then process that in a way and make sure that we're still on the same page when you've already arrived at the conclusion, and do we, you know, as a patient agree with where that conclusion is going?
Thank you. So I'd like to open the questions up to the floor. Questions? Yes. I'm not going to walk around with the microphone.
Thank you.
Thank you. So at the CMA's Health Summit, just recently, they talked about the new industrial revolution, the artificial intelligence, the robotics, the digitalized healthcare. I wanted to know from each of you what you think, or how you think this will impact your particular specialty. Your decision about testing, do we just scan everybody and then we get the answers for the medical records? Are they safe? Are they secure? And for the relationship, what if I never see my doctor? What if I just email him? What if I just text him? Which is where it's going.
3 concise questions there. Clinical data communication.
I'm the health person on the panel, so let me start by saying that you can make digital records actually much safer than you can make paper records that are transmitted by fax. Number one. And there's a lot of ways that you can do that, and creating things that have secure systems and audit trails are far better than something that, you know, is a technology that should have been tossed many years ago. So, but to answer sort of in the near term, what we're doing with some of the data that we have is actually using some of these advanced techniques. So using really high-powered computers to actually understand some of the nuances in the records. So we don't really use the free text, the actual notes, in any meaningful way. And so one of the things we're trying to develop is the technology to be able to understand what's in the notes, and that may actually help us detect things. So things like rare diseases or diseases that get misdiagnosed, when you start looking at actually the notes, you might be able with computers to actually pick out some of the symptomatology. You might also be able to do some of that same kind of thing in sort of a more advanced way with patient intake type forms. So maybe not an email, but maybe like a patient survey, and then you can use advanced computing techniques to help present likelihoods. And so where a lot of the technology is moving is using combinations of information in more sophisticated ways. So as opposed to trusting only the heuristics of a doctor's brain, sort of complementing that with some of the power of computers. And to complement that both technologically, so with means of communicating, you might say asynchronous communication, or things like email, where you're not necessarily, you don't need to be in the room. The thing about email, and the reason why we all use it for our research and administrative work and not with patients, is because it's actually quite efficient, right? If Roger sends me an email, I don't have to respond to it that second. I can respond to it the next day, and sometimes the day after. I try to get Roger's emails right away.
Sometimes 3 months later.
Sometimes 3 months later. But there's a certain efficiency because you can kind of, you don't have to be there at the moment. Whereas I can only really see, you know, if I'm super busy and super efficient, you know, 20 or 30 patients in a day. But I can respond to hundreds of emails. Well, I get too many emails a day, but that's a separate issue. But so that's part of the power of sort of leveraging some of those technologies. And I think you're going to see more of that in medicine.
So, from a family medicine perspective, some of what you're describing is the ways that information technology is changing medicine, what it means to be a physician. I train family physicians, and I have no concerns that they are going to be out of a job anytime soon. That I can make a little app for you with a little Snoop mnemonic, like with those red flags. Someone has got to communicate between you and the app, because those red flags sound nice and simple, except that someone has to interpret, like, what do you mean by new onset? Like, how different does this have to be? It's supposed to be changed from the previous path. How much changed is changed? There's a lot of communication that has to happen in that. In addition to which, people have a lot of other issues that are happening. It's closer, like that. People have a lot of other issues that people communicate about many different things simultaneously. So they're both telling you their symptoms, as well as they're telling you their fears and their ideas, and you're having to listen very carefully to hear exactly what you are being told, which is one of the reasons why I think we're a little bit of ways away from doing a lot of medicine by email, because there are a lot of things that you read in a face-to-face encounter that get lost in emails.
Okay. So that's why I said the word complement, not replace.
And there is still always concern that people have been doing research around of seeing what impact does it have for a patient's having a sense of trust around what their physician is telling them when their physician is staring at a screen as they're tapping and click, 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 the various things that you're telling them, and how much of those those imperceptible cues that we provide based on how we maybe change our shoulders and slump, or kind of move back, or quieten down, or get louder, and our facial expressions that maybe as we're trying to describe whatever it is that we feel is wrong, and how it's getting picked up when you're, looking at a screen. At the same time, I don't think we can go back to just days of, face-to-face with writing down, so it's trying to find that sweet spot. So hand over
Thank you.
there.
Yes.
Back corner spot.
Corner.
I just have a question about the vitamin D testing. I wasn't sure if I understood what you were saying. Are you saying that it's not useful for screening, or it's not useful for anything? Because I know of people who are having orthopedic procedures and osteoporosis, and their rheumatologists are testing them for vitamin D, and communicating with family doctors, all that stuff. So is that like unnecessary?
I could paraphrase Dr. Singer, just take the vitamin D.
Yeah, no,
Yeah.
that's what I wanted to clarify. I wasn't sure if I heard properly.
So let me walk it back a tiny bit. There are a few very few, very small in number, indications for vitamin D testing. Many of them actually relate to kidney disease and not necessarily orthopedic disease. Dr. Boehm is the orthopedic surgeon in the room, so he can comment about orthopedic disease, but for the most part, when it comes to osteoporosis, again, for the vast majority of patients, the testing of the vitamin D doesn't change the recommendation. If you have osteoporosis, you should be taking vitamin D. If you're at risk of osteoporosis, so basically everyone that's alive, like you live in Winnipeg, basically everyone that lives in Winnipeg that is lucky enough to be old enough to have osteoporosis, you should be taking vitamin D. So the test doesn't delineate, it doesn't tell me like, oh, this person should definitely take it and this person, and they probably don't need it. You should take vitamin D as a general rule unless there's some reason you can't for very rare reasons. So that's the issue. There are some very small indications and there are a few, but they're very few and far between.
I think there's really this example really speaks to appropriate use of tests and the ability to take a test that provides really no value or low value for patients, which is actually, this test was consuming a lot of resources 3 or 4 years ago. We were doing tens and tens of thousands of these tests in the province, not adding value to patient care. So when we drastically cut back the volume of tests we were doing, we could take those resources and put them somewhere else and do tests that provided value to patients, right? So that's an important consideration as well. More questions? Yes.
Thank you for this. I've enjoyed it. Question your perspective on the lack of sharing of information that may result in more tests. And I might add, not just sharing from one doc to another within primary care, perhaps hospital, but perhaps even naturopathic and or chiropractic care.
That's out of my wheelhouse.
That's out of your wheelhouse. So I think our systems of sharing testing in terms of duplicating testing have advanced quite a bit in the last few years. So we've actually advanced in Manitoba quite well in sort of reducing the kind of duplication that happens when someone shows up in the emerge and they don't know what your family doctor did. That kind of testing is hopefully getting less and less common. In terms of sharing the information with the patient directly, so like at the sort of bedside or in the office, it's a bit more challenging. And I mean, I just reflect, one of the trends we saw was that people who have providers who have larger practices were actually much more likely to use antibiotics for viral infections. And probably, if you think about why that's happening, it has to do with the fact that they're trying to see more people in a day, and often sharing that information to not prescribe an antibiotic both takes time and takes a more robust risk assessment. So if you're being very cautious as a provider, well, I'm not totally sure if this is a pneumonia or just a common cold, so I'm going to give the antibiotic just in case. And that's a common trend that people follow, sort of the just in case kind of usage, without thinking of the harms, but thinking of, well, I once had that person who died from pneumonia, so I better not let that happen again. And that drives a lot of, provider and patient anxiety drives a lot of testing and treatments. So taking the time to look for those red flags and make those careful assessments, it takes time. And so that's sometimes where that information sharing needs to happen. And I'm not, so that's where I would go. In terms of sharing among other providers in the system, so for example, chiropractors or naturopaths, I mean, I think the capacity to do that exists, in sort of quote-unquote old-fashioned ways by fax or patients bringing pieces of paper, but my experience has been that often that information doesn't help me typically make a decision for many cases. But it's hard to say, and it depends on the particular issue.
Yeah, and part of your question, which I was like, no, that's outside of my wheelhouse, was like the sharing between, say, naturopaths and chiropractors and maybe family physicians and things. I think part of the move, not to touch on that, but in terms of having EMRs, electronic medical records, thank you, is to be able to try to hopefully have some of that information kind of follow the person a little bit better. So if they are in the ER, those things can be accessed so that you're not doing those kinds of duplications. And Alex is right, it's a lot of times it's that having the time to talk about some of the things in the encounter that's where the time is needed, and the time's not always available, either because there's too much pressure on the practice in order to see more people. Everybody gets grumpy because they've been waiting in the waiting area for however long to finally see their doctor, and that plays strong. And just being able to have that time to go through things thoughtfully.
I have a question that, perhaps you can, this is kind of the result of old guys sitting around having coffee. Sometimes we're very frustrated because the slow play comes and we get this test and another test, and then, 3 years later, you finally sent the doctor home, he puts you in the hips in, and the world is great. The other thing is if you have perceived to have something with a heart issue, they rush you to the hospital, and you don't have that time to think about what's going, and ultimately it's your decision what happens. So they do it, and you come out with a bunch of medication, you don't know what you should have, and there's no process that says, okay, you got out last week, you should be reviewing this thing, because the doctor said, yeah, you had this, take that. But the third thing, and it's interesting you brought up the PSA, because that's where I see it's really difficult for people to make a decision. Just to give you some examples, one guy's 60 years old, his doctor doesn't do PSA, doesn't do DREs, doesn't do anything. Another guy's 40, his father died of prostate cancer, and the doctor suggested, well, maybe you should just get it taken out in case it's, and he's just got like preschool kids. And then, somebody has a PSA, it's high, and they're advised, well, there's another test which you have to pay for it. And if you don't want to pay for it, well, you'll have a biopsy, you'll have a bone scan, and you'll have some other test. I don't know. And if you ask for a second opinion, well, there's something else. Now, how do you have some idea how you get the right urologist or whatever? Other than just demanding a second opinion right off the top. How do you know when there's not enough tests or there's too many tests?
Yeah, there's a lot of points in there. So,
Roger wrote an article about this.
Sure. Yeah, please.
My response would be, first of all, you pointed out how it is complicated. It is also complicated to communicate effectively to patients when, so even in my shades of gray sort of analogy, you could see two doctors, one of whom says it's, well, 60% likely to be pneumonia, probably. The other one says, no, I think it's 60% that it's bronchitis and not pneumonia. And you might think that, well, someone says bronchitis and one says pneumonia, make up your mind. You can't, they're completely different. No, actually, they were pretty close to each other. They were both saying that it's almost 50-50 as to whether it's one or the other. So my point is that there are times when it's difficult as a patient to understand the conflicting messages that you seem to be hearing. Sometimes they aren't as conflicting as they seem. And sometimes they are conflicting. Sometimes doctors disagree with each other. In terms of a strategy for this, I would suggest a very straightforward one, which is find somebody that you trust and trust them. And the second part of that would be important, which is that if you go second guessing your doctor and kind of saying, I want this test, I want you to do this, I want you to do that, I don't think you're going to get better care. I would say find somebody that you trust and trust them.
Yeah, I would just add one small thing to what Roger says is when you trust someone, you can build on that trust. You have those conversations about, because often the question is really, is this the right test for me? Given all of the other things going on. So it's not as simple as, well, every 40-year-old whose father died of prostate cancer should have a prostatectomy. Sometimes the right answer is what's the right decision for that person. And that's why you need to have that kind of trusting relationship.
But everything that they've been talking about is when you have a regular doctor that you see, right? And so when you have a regular physician that you can see and who has gotten to know you, it's possible to have that kind of trust. It's when you're shunted in different ways through different providers, and because there's a whole variety of other circumstances, developing up that trusting relationship, that's where it gets really, really hard.
But doesn't that happen when you have this referral? You go to your GP, well, I don't go to your GP, don't get me wrong. Well, go to this guy for a test. Well, something that, and you you have trust with your GP, but as you go down the process, you talked about anxiety, waiting for diagnosis. Sometimes you just cut it off and let's get it over with. I mean, that's really difficult to build in the present system, especially when everything you hear about is we're cutting this, we're cutting that.
Yeah, and I guess the other trick is to try to loop back. If you go off to a specialist and you get some advice, there's never a problem with reopening that communication back, so closing that feedback loop. But it often is challenging, especially if you're in hospital for something urgent, right? Those things need to be done quickly, but there's a time lag before you get the information completely. So it is tricky.
Thank you. Question back here.
Thank you. A question for Dr. Singer. eChart Manitoba has, lab results, diagnostic testing results, which is available to all authorized providers. Has any of your analysis looked at how much that's impacted on changes to convenience testing? Like the doctor, rather than trying to track down the results from the specialist, the other doctor, well, I'll just send you for more results. Whereas eChart, the other doctor's results are there. Wherever that person has gone, the results are there. Because my experience has been when I see my doctor, when I've gone to the doctor with my parent, I say, well, do you have access to eChart Manitoba? And I've heard responses like, oh, I can't be bothered with that. Or it's been, all the results aren't there. And it's like, well, I'm pretty sure that they are. So I'm just wondering how much is being done to help continue to educate physicians about this resource to help reduce the duplication of testing, to look for results that might already be there.
So I'm not aware, I could be wrong, I'm not aware of any specific research that looks at does use of eChart actually reduce duplication. I think we assume that's the case, but I don't know that anyone's specifically studied that. In terms of access, so if your family doctor or doctor says, well, I don't use eChart, I mean, that's a personal decision. The rate of usage has gone up and up and up over the last few years. That doesn't mean that everybody uses it. It is a useful tool if you choose to use it and if you have the capacity to do so. So I can't say that. One of the challenges with using, so here's my political push, you should write your MP about this. One of the challenges of doing research with eChart is that the legislation that enables eChart to exist actually specifically forbids it to be used for research or quality improvement. And that was in the original legislation. So it's actually very challenging to do research using data from eChart, despite what a fantastic resource it is for patients and providers sort of in direct care. But the actual legislation forbids eChart and it says it can only be used for direct patient care. So that may be one of the roadblocks of actually trying to answer the question you specifically asked, which is, does eChart improve care? We don't exactly know.
If you're basically healthy, are there tests your GP should order for you anyway, or are you against all testing?
So I wouldn't say I'm against all testing. When we talk about testing healthy people, we're talking about screening tests. And there are a small number of screening tests for healthy individuals dependent on age and gender, right? So men shouldn't have mammograms.
Men do get breast cancer, but they shouldn't have mammograms.
Correct. About 1% of breast cancers are men, something like that. I'm throwing that number out of the air. You can look that up and tell me if I'm wrong. That's what the medical students do all the time, in the middle of the lecture. So, you're wrong, Singer. So there are a small number of what we call screening tests. So tests for people who are otherwise healthy to detect diseases early. And as I said, they're few and far between, but things like pap smears for women between certain ages, right, between about 25 and 69. And then some of them, even some of the screening tests that are widely accepted are actually a tiny bit controversial. So even mammography, the number of people needed to screen to actually improve the mortality is actually quite high. So it's even that's a little bit controversial, or a lot controversial, but still, for the most part, the balance is on the side of doing it. So as far as like general blood tests, sort of what one might say like routine blood work, there's really no role for someone who's otherwise healthy and feels fine. So that's...
So I have some numbers to add to that.
Oh, good. Wow. Thanks, Roger.
Which are So the two of the tests that in family practice we would usually recommend on a routine basis. So in this case, on my red flag analogy, just getting to be over age 50 is one of the red flags. When you get over that, like that is a red flag. So you shouldn't get it if you're before that, but under that circumstance you should. So those two, or I'm going to pick two. One of them would, well, let's just pick one. Go with a colonoscopy. So, or specifically screening for colon cancer. So when you turn 50, they send you the envelope in the mail, and you send it back off. And then if it's positive, then you go for another test. You go for the colonoscopy. That whole program, you have to screen 500 people in order for one of them to avoid dying of colon cancer. 500. So is it worthwhile? I would say, yeah. So there are a few tests that fall into that category of, I do recommend them. I'm over 50 and I do them myself. But I also am aware that the benefit is relatively small. Mammograms are the same kind of category of like 1 in 500, something like that.
788 against
or 788 or something.
I don't know many numbers.
You did the 788 one, you know. As you get older.
There's a part 2 to the question.
Yeah.
Well, so how often after 50?
Should you go see the doctor?
Well, what about a fecal test instead of the colonoscopy?
So it's part of like, you think of it as a package.
Oh.
So you do the fecal blood testing, and if it's positive, then you go for the colonoscopy. So I think of them as one test, because one is a whole program. The program like that.
Okay. If you're okay, how often do you have to go for that? Hopefully never again, I'm hoping.
You're asking about colonoscopy or the...
Either.
So if you never have a positive test and you just keep on sending in your negative tests, then I believe it's every 2 years.
Yeah, and so one of the interesting, just to bring up, one of the Choosing Wisely recommendations is to not have annual physicals. So the annual physical is sort of a tradition in medicine. This is maybe very revolutionary. I see some minds blown here. So the annual physical comes from the days when insurance companies wanted to know that all the people they were insuring were healthy. But there's actually very poor evidence that seeing the doctor just because once a year actually improves anybody's lives or lengthens them or makes them healthier. So one of the Choosing Wisely recommendations is to not do annual physicals. And what we've moved to in our residency training is to talking about health reviews. So tailoring how frequently you should go based on what conditions you have and how well you are, how old you are, what gender you are. So for many people, younger people, otherwise well, they should probably see the doctor no more than every couple of years or every 4 or 5 years, maybe. Right? If you're a young woman over the age of 25, probably the minimum is something like every 3 years to have a pap test, right? If you're a bit older and you have diabetes and heart disease and other conditions, maybe that rate is something like every 3 months. So really the message is not to just have an annual physical for the purpose of just, okay, well, it's been a year, so let's chat, but more to tailor it based on what conditions you have.
Yes.
I was interested to hear the amount of research that you're doing in relation to perhaps unneeded medical testing. You also indicated that you, in the research and the data that you've generated, you identified certain physicians or practices that are overusing or using more than needs to be certain testing. So one of the things that always strikes me about research is that things are learned, and then it's like throwing a paper airplane into the mist over Niagara Falls. You don't know what happens to it. So, I guess the question I have is, you are spending a lot of time, a lot of resources, a lot of people's efforts to discern certain practices that are going on. what leverage do you have, or do you have any leverage in influencing the behavior of physicians?
So if you listen really carefully when Eric went through my bio, which it was quick.
They were really listening carefully.
So I actually have 3 day jobs, well, sort of 3.5. One of them is to clinician and teacher. The other one is research. And the third one is actually about quality improvement and the use of the data to improve practices. So that's, I think, what you're talking about, where the rubber meets the road. So about a third, give or take, of what I do involves both trying to deliver that data to physicians to change behaviors, use the resources, the processes, the system that we have to sort of advocate to system stakeholders, so like, let's say like the CEO of DSM or something like that, Diagnostic Services Manitoba, right? So sort of to advocate to have some of those policies that actually drive good care or the best available care. And so that's partly what I do, is actually take my research and bring it to the, you might say, the bedside. But I agree with you, there's really very little value in doing research if it's not going to be shared, it's not going to drive change. So a lot of the research I do is actually around what you might call sort of implementation science. So how do you deliver these things, how do you actually package the data in ways that are useful to people? And that's a lot of what my research is. It's actually not quite as esoteric as it seems when I rattle through a bunch of numbers, I hope.
So that's an excellent question. It's a bit of an area of interest of mine as well. I have an engineering background and an orthopedic surgeon, so I like cars, right? I worked at GM person actually. And it always amazes me when you go and buy a car, you can go to Car Cost Canada and figure out exactly how much a car is going to cost you. You can go to Consumer Support and figure out how long the car is going to last. You can make an informed decision when you purchase the car. And traditionally, we've done a fairly poor job in healthcare of measuring and reporting on what we do. And in my role at the Center for Healthcare Innovation, we're trying to improve that process. And we've got lots of examples in my world of orthopedics, for example, of measuring outcomes and feeding that data back to surgeons. And there's all kinds of steps you need to go through. You need to collect the data, you need to analyze it, present it in a way that's intelligible and interpretable to people. Often providing somebody with their own data and their peers' data to show them that they may be different from their peers is a good motivating factor. Then, of course, you need to have sort of a bit of a stick. Perhaps that data goes to a standards committee that can look at physician performance. So I think traditionally we've done a fairly poor job in medicine of doing that, but it's changing. But that's an excellent point. And this is obviously the step of the research and what we're doing is to translate this knowledge and data into improving care for patients.
Eric, I just want to add so that some of Alex's data, one way of looking at it would be that, okay, they're bad physicians who are ordering too many tests. And I would say that as opposed to either completely disagreeing or agreeing with that, there are also times when there are differences of opinion, different interpretation of the evidence. There are also times when people have somewhat conflicting values. On my scale of black sort of to white, I said that toward the far end, like you start to get more and more harms as you push towards zero. Well, some people value the harm of missing something differently than they value the harm of all of the false positives that are generated. And so there are, I think, sometimes legitimate differences of opinion that drive some of those differences in practice.
That's absolutely true.
And that's also one of the reasons why in a lot of the current research initiatives there has been a stronger push not just to allow researchers to think, oh, well, I'm really curious about this, so I'm going to study this, because that's often how a lot of it went. And there's more and more efforts and initiatives to try to engage people who have lived experiences with particular conditions, with particular and unique sets of knowledge that are just as valuable as all of the databases in the world, to help make sure that the kinds of questions that researchers ask, that the kinds of outcomes that are being measured are also the kinds of outcomes and questions that matter to the people who are ultimately to be served by any of the research, and that's all of us. when any kind of health research goes on, we're ultimately the beneficiaries.
Which is exactly why you should sign up for the patient advisory committee.
Well, I have one too.
You have one too?
I have one too.
For either of our studies.
Or both.
Or both.
There are a couple of things that I wanted to say. One, I do go down for an annual physical, and what was picked up at one point was high blood sugar. And I've now been living successfully with type 2 diabetes for what's going on 20 years, not even on insulin. So the doctor thinks I should go down and see him every 3 months, but I go down once a year, regularly. And the other thing, I hope you don't think I'm being cynical about this, but when the doctor upstairs in the clinic is a part owner of the lab in the basement, do you think that might be considered a conflict of interest?
So
yes,
yes, potentially. There's lots of incentives. If you think about this from sort of an economist eye view, there's lots of incentives involved. Some of them are just to get out before lunch so that you have some time to eat, or get home so you can pick up the kids. Those drive some care. And there's a great study that I love from California that looked at antibiotic prescribing, and you can actually see the rates of antibiotic use climb just before lunch and just at the end of the day. And this is over hundreds of thousands of encounters. There's sort of this consistent climb, and then when you do an intervention, it ameliorates and goes back to sort of baseline, and then when you pull the intervention away, you stop giving people their feedback, it just slowly equivocates back to the previous. So there's lots of incentives, both financial and time and other. In terms of how best should you manage a particular disease, that's a decision that you've got to make and you've got to be comfortable with. And knowing that you have diabetes maybe suggest certain things that you might want to do about your health, but that's a conversation that you need to have, and you have to be comfortable with the decision about how often you're going to get tested or not tested or screened and all those kind of things. So there's a conversation that needs to happen.
And I mean, it's like what Roger was saying, that there's different values, right? Some people they come from the perspective of quality of life matters more than life at any price. So there are trade-offs that come with that in recognizing that, you know what, I don't think I want to go down that path even though it might extend my life, because I want to be able to enjoy the time I have. And that might even start long before you know that there's anything really seriously wrong, but just a case of, no, I really don't want to be going down certain paths, and that's what you've chosen to do as a person, and that should be fine.
Yeah.
Got one more question here.
I think Eric said you shouldn't ask specific medical questions.
Yeah, so speak to your primary care provider. It's about 1,000 units a day.
Yeah, it's about 1,000.
Because I'm sure Choosing Wisely actually has a recommendation.
1,000. It's 1,000 give or take. If someone tells you 1,200, they're probably still right. If someone tells you 2,000,
800's probably.
800's probably fine too. It's somewhere between 800 and 2,000, but 1,000 is the sort of ballpark number that's about right.
I told you not to ask 2 doctors.
And the truth is, the reason there's this sort of range is because there's different studies with different numbers, and they give different outcomes. And so some people would argue, take 2,000, because well, if you miss a day, well then that's enough, and you're okay. And some people say, well, 800 is really all you actually need, right? And there's some studies that show that that's quite a bit, that's quite enough. So there is a bit of a range, but if you can get a pill that's 1,000 and take that once a day, you're probably good.
If that was too complicated, then 1,000 was the answer?
Yes. Oh, you can get quite ill. Off the top of my head, I won't go through them all, but if you can actually take too much vitamin D, and it can cause quite a number of problems, both bone and abdominal problems. And there's a whole range of things. So yeah, too much. There is such thing as too much of a good thing, both with tests, treatments, vitamins, medications.
It is way over 2,000 though.
Oh yeah, it's like 6 or 7 or 8 or 9 a day. 1,000.
Any other questions? Hopefully one more at the back here.
I'm just wondering if any of the research has shown if knowing the costs of tests, like per test, changes behavior at all. whether for the patient or the physician, or it doesn't have an impact?
There definitely, so I don't know the 100% answer to this. There is data from the US that looks at insurance coverage, and that definitely drives lack of testing. So not having coverage actually restricts use. In terms of physician behavior, I don't know that literature really well, so I hesitate to comment, but intuitively it might make sense. The truth is most people don't really care. Most patients don't care, because if I told you, well, you know, this test is $100, like, are you sure you really want it? You're like, well, I'm paying my taxes, it's, you know. But nothing is really free, right? You're just insured. We happen to have a single payer insurance system, so you don't actually see the bill. But there was a time in Manitoba where patients used to receive an invoice. I don't know if any of you experienced this, but you got an invoice and it just said, like, okay, in the last year you used, you know, $16,842 in healthcare. And at some point they just stopped doing that. I don't think that there was much benefit. And doctors used to get this big long tabulation that they abandoned years ago because probably the printers all broke.
There have also been studies in hospital where for physicians who were ordering the test, they would just put like the number of what it costs beside them. And I can't remember whether the effect of that was little or none.
Because the truth is that at the time of making the decision, you either think it's necessary or it's not. And generally the cost, certainly for the physician, doesn't change it because it's not coming out of my pocket, generally. And for the patients, well, if it is coming out of your pocket, I mean, we know this with pharmacare coverage, right? People don't fill their drugs if they're not covered quite often, and there's definitely trends in terms of medication filling of prescriptions. But the same is true in settings where there's co-pays, you pay a certain percentage, or where things aren't covered at all, so people don't go for tests. But at the same time, it also enables some over-testing. So there's some evidence that, you know, if you have a gold-plated insurance coverage in the US, you're actually much more likely to get certain kinds of unnecessary tests. You're like, well, I'm already paying all this money, I better get my full-body MRI. And then that leads to other harmful problems, and then drives up the cost of your insurance, and then you're paying more for the insurance. You figure you might as well get your money's worth.
If you get a full-body MRI, the likelihood that you will have a false positive is about 1 in 2. Every second person has like some little something in their pancreas, some wherever.
Extra bone in your toe.
And the other reality is when some of those studies might be done to see what impact it would have, we behave in a particular way when it's kind of a hypothetical scenario, and we're often a lot more rational and logical when we're approaching things from this hypothetical scenario. But then when you're faced with it, in terms of I might need something or there might really be a problem, the cost really is irrelevant at that point. And at least we're lucky in a system where we don't end up being mortgaged to death because we're having to make those choices that do exist in the US. So.
I think one of the costs that providers might see is unnecessary waits for tests. If I ordered MRI scans and all the patients that I saw with knee arthritis, I'm going to create even longer waits for MRI scans. And when I have a patient actually needs an MRI scan, it's going to be hard to get them in there. So that's sort of a cost perspective that we see. If we have no other questions, I think we'll wrap it up there. So I want to thank you again very much to our speakers for coming to speak with us. And to the audience for your participation and excellent questions. Donna Robinson for hosting us, of course. And next month's topic takes place here on October 29th. At 7 p.m. and it's entitled Polypharmacy, Are We Over-Medicating Older Canadians?
I can see Mr. Khan, yes.
So please remember to fill out the evaluations and leave them on the chairs or on the table here with the materials. Thank you again. Please eat the food as well. You're welcome.